Pacific Glaucoma Society and Bangladesh Glaucoma Society Joint Symposium. With us are a lot of renowned speakers, both internationally and also from Bangladesh. We have here Professor Nazrul Islam, who will co-chair this session with me. We have Dr. Iktihar Munir, Dr. Colin Clement, Dr. Verna Octriana as the speakers. We also have Professor Zaika Shahid, who will give her insights regarding the talks. Before we begin, maybe we could get us a welcome address. Professor.
Dr. Norman Aquino from APGS, our Secretary General.
All right. So in behalf of the President and the Executive Board members of the Asia Pacific Glaucoma Society, I'd like to welcome all of you to this joint symposium. As you all know, aside from education, another mission of the Asia Pacific Glaucoma Society is to foster strong relationships among the different glaucoma societies within the region. And therefore, activities like this are clearly able to achieve these two goals. The APGC is very grateful for the efforts of Dr. or Professor Nazrul Islam for spearheading and planning for this event and making it possible for us to join the Bangladesh Ophthalmologic Society in their annual meeting. So again, I would like to welcome all of you to a session which I feel is going to be very beneficial to all of you who will be listening, simply because it entails a topic that is very relevant and very important for all of us clinicians to know and hear about. And this is regarding challenges and difficulties regarding glaucoma surgery. So again, thank you very much. And I wish you all the very best for this meeting. Thank you.
Thank you very much, Professor Norman Aquino. As the Secretary General of the APGS, we're really happy to join with us and have your comment. Thank you so much.
Okay. Professor, you want to introduce the first speaker?
I think that Professor Zakia Sultana Shahid,
oh yes,
our President-elect, she have some comment.
Oh yes.
Thank
Professor?
you so much. On behalf of Bangladesh Glaucoma Society, I'm President-elect, Professor Zakia Sultana Shahid. Very happy to see all of you with us. And I welcome you to 5th National Glaucoma Meeting and 13th Annual National Conference arranged by Bangladesh Glaucoma Society. I hope that the joint collaboration between APGC and Bangladesh Glaucoma Society, this will be helpful for a big population to exchange our views and exchange our ideas. And I must thank Asia Pacific Glaucoma Society to be with us in hand. Hope the next session will be a wonderful one. I am very much thankful. We, Bangladesh Glaucoma Society, also very much thankful to you. Thanks a lot.
Thank you, Professor Zaika Shahid. For the audience, if you have any questions during the talk, feel free to put it in the chat box and we will go tackle it during the Q&A session. Professor Nazrul, would you like to introduce the next speaker?
With the introduction, we can start our session with the first speaker, Professor Iftikhar MD Munir. Professor Iftikhar MD Munir is a glaucoma specialist in Bangladesh. He was the head of the Department of Glaucoma Division in the National Institute of Ophthalmology in Bangladesh. Now he is working in as a senior consultant glaucoma at the Bangladesh Eye Hospital. At the same time, he is also the Secretary General of Bangladesh Glaucoma Society. Over to you, Professor Iftikhar MD Munir. Please unmute and share your screen.
Okay, কথা বলি আমি। Respected chair and co-chair person of the joint conference of APGS and BGS, honorable co-speakers and learned audience. Assalamu alaikum and very good afternoon from Bangladesh side. As I welcome to you to my presentation, Improving Trabeculectomy Outcome. As it is recorded, so I try to start the record. My presentation, Improving Trabeculectomy Outcome. Trabeculectomy is a gold standard procedure for glaucoma operation because in the third world like Bangladesh, usually glaucoma are late presented. So the needs target IOP very low, and the trabeculectomy can reach the target IOP to a single digit, and the operation is relatively less costly, and the instruments which are needed for the trabeculectomy operation are widely available and low cost, and it can be done where microscope is available. The surgeon who is trained can do trabeculectomy operation. But glaucoma drainage device is reserved for the refractory glaucoma and secondary glaucoma, and MIGS for early glaucoma. Now, what is trabeculectomy? It is a surgical fistula between the anterior chamber and subconjunctival space by removing the trabecular meshwork. And trabecular bleb, a term always related with the trabeculectomy operation. It is the controlled leaking area of aqueous humor in the trabeculectomy side. Trabeculectomy operation nowadays, adjunctive mitomycin C nowadays widely used. It causes increased aqueous outflow, which is causes lowering the intraocular pressure. And in some cases, it causes a vascular bleb, and a vascular bleb is always related with hypotony and endophthalmitis. In my presentation, I try to focus how we can improve the trabeculectomy operation outcome and what are the things I usually follow during the simple trabeculectomy operation. I try to focus it in this presentation. Different adjunctive are used for trabeculectomy operation. Collagen implant ologen. It is a porcelain porous protein. Its pore usually loses the proliferating fibroblast, so there is less fibrosis in the bleb area, and it causes less avascular bleb than mitomycin C. And when it is applied subconjunctivally, it also acts as a space agent, so it helps in formation of the bleb of the trabeculectomy operation, and it is within few weeks to month, it is auto degraded and replaced by spacious trabeculectomy bleb. Fibrin adhesive, it is another adjunctive. This adhesive glue usually used instead of stitch material, so it is less toxic to the tissue and so less inflammation, and it is also autobiodegradable. Amniotic membrane transplant, when there is conjunctiva is defective, amniotic membrane can be transplant. We know amniotic membrane is less antigenic. It has different properties also. It is anti-fibrotic, anti-angiogenic, and antimicrobial also. So when there is any conjunctiva is defective, we can use the amniotic membrane as an adjunctive. Anti-VEGF nowadays also used in the intracameral area of subconjunctivally, but it is still now in the research pipeline. Antimetabolites like MMC5FU nowadays widely used as an adjunctive with trabeculectomy operation. Now the patient selection. During patient selection, we have to identify the risk factors. First of all, we try to take the history. Is there any trauma or surgical history? Try to see lid margin. Is there any inflammation? Conjunctiva, whether it is virgin or there is any scar tissue. Is there any sign of uveitis? Is there any new vessel? If there is any risk factor, we have to take a measure. Otherwise, trabeculectomy operation may not be good in the postoperative period. Preoperative consideration. 3 days before, we have to stop the mitomycin and prostaglandin analog because to drug causes conjunctival condition. And we have to add non-steroidal anti-inflammatory drug 3 days before surgery, so it can combat the inflammation. We know in the congested conjunctiva or inflamed conjunctiva, there is more number of inflammatory cells. If the more number of inflammatory cells in the conjunctival space, the postoperative period, it may be causes failure of the bleb. So we have to combat it preoperatively. If the patient take any blood thinner and antiplatelet drug, they should be stopped 5 days before surgery. Perioperative procedure for anesthesia. Anesthesia may be perivalvular or topical and subconjunctival anesthesia. It depends upon the patient condition or the surgeon's choice. Eyeball rotation by bridle suture or limbal retraction suture by 6-0 Vicryl. It also depends upon the patient condition and surgeon choice. Mitomycin C can be given by sponge application or subtenon injection. Subtenon injection, I think, is better than the sponge application because it is applied more posteriorly, at least 8 to 10 millimeters from the limbus. Conjunctival dissection is very easy, and as it is less concentration of mitomycin, so there is less chance of avascular bleb in the postoperative period, and there is no risk of retention of sports material in the subconjunctival space. So I think this subtenon injection during operation is a new modification in the simple trabeculectomy operation. During deep scleral flap, it should be more anteriorly. You should not extend scleral spur because if it is extend scleral spur, it may injure the ciliary body. So there may be chance of perioperative bleeding. And iridectomy site should be adequate. At least 2 to 3 ciliary bodies should be seen through the iridectomy site. In triangular scleral flap, I usually use 3 stitches, 1 stitch at the apex of the triangle, this is fixed stitch, another fixed stitch at the one limb of the triangle, and third stitch I always give a releasable stitch at the another arm of the triangle, and it is removed in the first postoperative period depending upon the intraocular pressure and anterior chamber status. And conjunctiva replaced to the limbus, and it is anchoring by 2 anchoring suture on both sides, and this side should be watertight, and this watertight adjust by fold of conjunctiva. If this fold of conjunctiva is present here, this indicates it is watertight. Postoperative care. In the postoperative period, antibiotic for few weeks, steroid for few months, and atropine is given in the narrow angle glaucoma a longer period than the open angle glaucoma because in the narrow angle glaucoma there is more chance of malignant glaucoma formation in the postoperative period. So in the narrow-angle glaucoma, atropine should be given a longer period than the open-angle glaucoma. Post-operative visit, first operative day, it is mandatory, and then weekly for several weeks, and then monthly for several months. In the postoperative period, postoperative complication should be managed in proper time with adequate technology and tools. Otherwise, trabeculotomy outcome may not be good. This is a simple trabeculectomy operation video. Here we try to see the steps of trabeculectomy operation. Usually I follow during the trabeculectomy operation. After fixing the superior rectus, proper wash and mitomycin C is given to the limbus subterranean area. It is widely distributed by cotton bud and wide dissection of the conjunctiva bone posteriorly. So, posteriorly diffuse bleb can be possible. During cautery, I avoid too much cautery because too much cautery causes fibrosis of the conjunctiva. I prefer triangular flap, and it should be extended in half thickness up to the clear cornea. And the parasynthesis I always prefer to make because it is needed in the per and postoperative period. This cluster should be more anteriorly, and iridotomy should be adequate. I already said that at least 2 to 3 cilia deposits should be visible through the trabeculectomy, iridotomy site. And regarding the stitch, 3 stitches usually I keep, 2 fixed stitch, and 1 is a releasable stitch. And releasable stitch I usually start in the radial direction, and it is end by taking 4 loops and tight it adequately in watertight. And it is removed in the first postoperative period, depend upon the intraocular pressure and anterior chamber status. And conjunctiva should be replaced to the limbus, and it is anchoring into the limbus by 2 anchoring suture. During these 2 anchoring suture, I judge it should be watertight in the limbal area, so there is less chance of leaking of aqueous humor. If there is any leaking, I try to give the mattress suture here. And finally, anterior chamber, some subconjunctival space is formed by water gets to the side port. This is a short publication published in the Journal of Ophthalmological Society of Bangladesh, 2019. Here, a simple comparison: 30 cases of trabeculectomy with mattress suture given and 30 cases without mattress suture given. And the result is compared. It is found that in the mattress suture group, the postoperative intraocular pressure and the bleb morphology is better than the non-mattress group. So by this simple modification of trabeculectomy procedure, we can change the outcome of the trabeculectomy operation. Now the summary: preoperative patient selection, proper perioperative technique, the management of the postoperative complication, with up-to-date methods and technology, we can modify the trabeculectomy outcome. And conclusion: ongoing research and development of innovative surgical tool and technique leading reducing complication and improving the trabeculectomy operation outcome. Thanks for patience hearing.
Thank you, Dr. Munir, for that very comprehensive lecture on how to enhance outcomes. For our next speaker, it's a privilege to introduce Professor Nazrul Islam. He's currently the president of the Bangladesh Eye Care Society and president also of the Bangladesh Society of Cataract and Refractive Surgeons. He's a board member of the Asia Pacific Glaucoma Society and also a past president of the Bangladesh Glaucoma Society. He has a lot of publications in various scientific articles, has written editorials, and he has been invited to speak in numerous international meetings. Professor Islam?
Thank you very much, Professor Tambakan, for your very kind words. Actually, it's my privilege to speak in this APGS Symposium, and I'm thankful to the APGS also for the opportunity. I'm working in the Bangladesh Eye Hospital in Dhaka. We have heard that trabeculectomy from Professor Iftekhar Muhammad Munir, and he has nicely described how to make it successful. But still, we know that trabeculectomy fails. So I'm going to talk on that, what to do when trabeculectomy fails. I do not have any financial disclosure. Let me see the trabeculectomy story here. As Professor Munir mentioned, you have to stop preoperatively the aspirin, clopidogrel, and the PZ analogs, pilocarpine. You have to give, if the pressure is very high, you have to give the intravenous mannitol. Definitely, you have to do a very meticulous surgery with the anti-metabolites like mitomycin C, 5-APU, anti-BGA, etc. And of course, you can, recently we are doing the subcanon mitomycin C, low dose mitomycin C, as Professor Munir also showed. I also practice like that. We can also use the collagen matrix, collagen as an antifibrotic agent. You can use the SC maintainer. In different studies showed if you give the SC maintainer, results become better. You can do argon suture lysis, you can do releasable suture during your surgery so that we have postoperative titration facility. If the facility is there, you may not do the iridectomy. Rather, you can put a shunt, express shunt, so that you have less inflammation. You can give postoperative anti-BGA. So everything we can do for a good trabeculectomy, but sometimes, most of the time, after 5 to 10 years, we find our trabeculectomy fails. And we know that this is expected outcome because the body wants to seal off the fistula that we made. After surgery, the body mounts an aggressive inflammatory reaction, which can quickly result in scarring of the blade. And definitely, we should see in the slit lamp if there is any early sign of failure of the blade or failure of the trabeculectomy, like if there is high intraocular pressure, even after massaging, the pressure doesn't come down, local conjunctival hyperemia, vascularization, flat blade, highly elevated cystic blade or tenon cyst, small avascular cyst. These are the signs we can see in the earliest stage if it is going to fail or not. And definitely we must examine gonioscopically also, because sometimes we find there is internal block by iris, ciliary body or vitreous or blood clot or fibrin. So we must exclude it. And if there is something present, we must address this for the treatment. Now, my topic is the options when the trabeculectomy fails. I have written here some agenda like digital ocular massage, argon laser suture lysis, releasable sutures you have done. If adjustable suture, you can loosening it, blade needling, again starting the medical treatment, revising our trabeculectomy. Minimally invasive glaucoma surgery has a role now after trabeculectomy fails. A repeat trabeculectomy, glaucoma drainage devices may be valved one, non-valved one, and laser cyclophotocoagulation. These are the possible options that we can use if our trabeculectomy fails. First of all, let us see the blade massage. If the blade is not oil formed, you can massage it, you can see superiorly, or you can massage it also from the inferior part, from the lower part also. The lower part. So this way you can make your blade a little bit functional. So even in the second, third post-op day, you can do it, but it should be done very carefully. And even with the facility of argon laser suture lysis, with the Hoskins lens, you can cut the laser very, very easily. So in my practice, mostly I give a little bit tight suture. And in the post-op days, if we find the pressure is going up, so usually I use multimedia C. Usually after a week, I try to cut the suture by the argon laser. So it really, most of the time, it helps to recanalization of the fistula. Now, release of the releasable suture is very important. If we put the releasing sutures, definitely after some days or some weeks, if you find the pressure is not come down, you can, of course, release the releasable sutures. And most of the time, after digital massage, you will find the pressure come down. Bleb needling, I like to give more emphasis on this because bleb needling is a really good option when the trabeculectomy fails. Within few months, you can try bleb needling. And you know, the needling is a kind of bleb revision procedure with the needle incision, and is a good option for the failing and failed bleb. And sometimes we do with the adjunctive agents like mitomycin C and 5-FU, and sometimes without mitomycin C, especially for the children, I don't use. So bleb elevation of the scleral flap is significantly reduced IOP for a long time. In a study from the NAI group, we find that in the conclusion, needle elevation of the scleral flap may provide significantly long-lasting pressure reduction in eyes with failing vitamin C blebs. Again, another study in the Journal of Glaucoma by Giddy et al. And Wilson et al. Found that a modified bleb needling procedure performed in the operating room successfully lower IOP in the setting of previous trabeculectomy, at least in 60% cases. But in some cases, you have to use the AC maintainer, they're advised. This is the bleb needling I usually do from the far away from my bleb, a little far away from bleb. I use 26 or 27G blade, but it is totally small. At the same time, it's quite firm. So going to the subtenon space first, because that is the area mostly fibrosis done. So in the subtenon space, already I forgot to tell, I have given the low dose vitamin C 5 to 10 minutes before the bleb needling in this case. And then I'm doing the subtenon separation. And then with caution, you go under the superficial scleral flap. And if there is a suture, you can cut the suture also by the needle. And going very slowly, cautiously, you can even go to the antechamber, but we should be careful. We should not go with a resistance that can cause inadvertent puncture and may cause hypema. So it is better to go very slowly and very easily to the antechamber. And you see at the end, there is an aqueous humor already come here. So you have finished your bleb needling and you can stop it here. Number 5, medical treatment. Yes, there's no harm if we start again the medical treatment if bleb needle fails. We can start with one anti-glaucoma medication. If do not work, you can go for 2, 3 like that. And of course, you can go for highest maximum medical treatment. And lastly, I will say that revision of trap is not bad. If it is done within few months, even 6, 7 months, usually it is possible to separate the tissue easily. Your previous surgery, you can just separate it. Maybe you had a very tight suture or there is some early fibrosis, you can separate it. And if there is tight suture, you can just make it loose or just light tight of the suture. We can do it. And finally, just like our primary trabeculectomy, you can see the ostium. If the ostium is small, you can make it bigger with the Kelly's pans forceps also. So you can modify our surgery again. You can give air in the antechamber. So this revision trap, most of the time, it also helps if the trabeculectomy, primary trabeculectomy fails. That regarding the mix, I say that nowadays people are using minimally invasive glaucoma surgery. Many options are there. So if we have the facility, we can also use the eye stent and other minimally invasive glaucoma surgery that is available in your hand. So after trabeculectomy fails, many studies are showing that MIGS is intermediate before your another surgery. So definitely you can start, if we have the facility of minimally invasive glaucoma surgery, you can do it. Kahook dual blade is another option. If the angle is open, definitely we can try the Kahook dual blade. We can do at least 120 degree from this here. I'm doing here about 60 degree. And again, you can come there another 60 degree. So Kahook dual blade is a goniectomy. It makes open up the antechamber. So the antechamber and the trabecular meshwork. So fluid can go easily, and it has been found in my study that it really decreases the pressure at least 5 to 10 millimeter of mercury. I'll emphasize on the bang because the bent angle needle goniectomy is very non-expensive in our country. So we can use it in exchange of the Kahook dual blade. It does not make any penny for us. Only one needle is enough. So you see, just like Kahook dual blade, I'm doing the same thing. The excision of the trabecular meshwork, you can see similarly like the Kahook dual blade, 60 degree this side and 60 the other side. So this way you can, of course, make the trabecular meshwork open at least 120 degree. That helps. And I have found in some patient it works. We do not need again another surgery, another trabeculectomy. 360 degree trabeculectomy is also good. If you have done trap first, then you can go open it and just put the proline, 4050 proline in the trabecular meshwork in the Schlem's canal, and then 360 degree, we can cut it. Definitely the whole 360 degree cut is there. Trabecular meshwork is open and the aqueous outflow will be higher. So this is another option. If you have the facility, you can go internally the GAT procedure or externally with the proline needle. So this is one of the non-expensive MIGS, I would say, that you can try after the trabecular fails as a second procedure. You can see it just cut the whole 360 degree by the proline. Now, of course, a repeat trabeculectomy is in our hand. You see, in this particular case, the patient had another 2 trabeculectomy before. You can see 1 and 2. I asked the patient to have glaucoma drainage valve implant. The patient could not afford it. So I had a modification of the trabeculectomy like a larger flap, giving the mitomesis C for more concentration and higher exposure time. So ultimately the patient did well. And it is another option that you can do the third trabeculectomy even that was possible. Definitely, there is the option of glaucoma drainage device because glaucoma drainage device is nowadays being very popular, even in the primary procedure in the neovascular glaucoma, inflammatory glaucoma. We are using the glaucoma drainage devices. Ahmed glaucoma valve here I'm using is really very helpful in the failed trabeculectomy. You can see this patient had trabeculectomy before, but patient had failed the trabeculectomy. So I'm doing the valve implant. And after Ahmed valve, the patient did very well. And the patient come down. That's a very good option. When the trabeculectomy fails, you can try the glaucoma drainage devices, maybe valve, or maybe the non-valved one. This is the non-valved one. And you can see the this is the RD, Orbion the aqueous drainage implant. It's a copy of barbell implant. In our country, it is comparatively very cheap. It's about $40 to $50. So we use very frequently for our patient who can afford the Ahmed valve or the other expensive valves. We can use it. So definitely we can use. Thirdly, I would say that this is another option of Ahmed Clear Path. This is the very comparatively newer implant. It is a non-valve implant by same Ahmed glaucoma valve, the same company called. So these are 2 model. One is 250, another 350. So I'm using a 250. The advantage of this valve is model is that you can roll it. You can roll it like a taco. And for a small incision, you can see here I'm making only 4 to 5 mm incision. You can put inside under the Tenon's capsule here. So then you can unfold with the help of another 2, like here the 2 Morphyl forceps. You can unfold it. So the patient having trabeculectomy, the space is less. So there is some fibrosis. So in that cases, I think the less small incision, the Ahmed Clear Path is really a good option for us, because it takes only a small area, 4 to 5 mm is fine. The procedure is almost same, only small incision, the latter part is almost same. You can just introduce the tube in the anterior chamber as we do in the other standard glaucoma drainage devices. It's the same thing. And after that, as it is a non-valved area, you can have a fenestration, 2, 3 or 4 fenestration, and covering the tube with the patch graft and suturing with the 8O vehicle you can see here. You can just give 2 or 3, and at the end you can see only 4 5 millimeter incision. So it is very option for the cases where the trabeculectomy fails. Lastly, I would say when everything fails, then there is a laser cyclodestructive procedure, especially for the non-seeing eyes. We can do cyclocryopexy and diode cyclophotocoagulation. But definitely with the seeing eyes, we have different options like endoscopic, cyclophotocoagulation, ECP, and micropulse laser photocoagulation. So in conclusion, I would say we can prevent to have any residual glaucoma with the meticulous surgery, as Professor Munir showed, starting with preoperative preparation, meticulous surgery, modification during surgical procedure. Postoperatively, if it fails, we have shown the different options that can actually salvage and most of the surgical failure and increase the survival and success rates of trabeculectomy and the other glaucoma surgery. So I think trabeculectomy is, of course, a gold standard surgery, but if it fails, we have many options in our hand to help our patient. I like to acknowledge the Asia Pacific Glaucoma Society for the exchange of program of the faculties with the Bangladesh Glaucoma Society. And with that, I'd like to thank you very much. Thank you.
Thank you, Professor Nazrul Islam. That was a very interesting talk. I like how you inserted the cost aspect of when choosing the next procedure. And it's quite concise and quite comprehensive in terms of what you would do next when a trabeculectomy fails. It's also interesting that MIGS was put into the picture after a failed trabeculectomy. Maybe we could, that's a point for discussion a bit later. We'll move on to our next speaker. Our next speaker is Dr. Verna Octriana. She's currently the chair of the Indonesian Glaucoma Society, staff of the Glaucoma Division at the Mangunkusumo Hospital, Faculty of Medicine, University of Indonesia. She is also a board member of the Asia Pacific Glaucoma Society. She completed her medical degree and ophthalmology training in the same university. He also had further training in other institutions like Royal Victorian Eye and Ear Hospital in Melbourne and the Royal Perth Hospital Lions Eye Institute in Perth. She has attended numerous courses, has given several talks, and she has even developed her own glaucoma drainage device. And I hope we could hear from her. So her talk is entitled My Glaucoma Drainage Device Experience in Refractory Glaucoma. Dr. Octriana.
Thank you, Pastor Bokpan, with a very, very nice introduction. And thank you for inviting me to talk in this APGS and in Bangladesh Glaucoma Society meeting. I want to tell you about my experience in refractory glaucoma. I want to share you several cases that I have done few years since I was in glaucoma practice. I start my glaucoma practice actually on 2007. Until then, I have numerous cases. I want to share you several cases that I have. The first one is a secondary glaucoma due to Graves' ophthalmopathy. This is a man with 44 years old with Graves' orbitopathy. He had been treated with bilateral 3-wall decompression and corneal graft of the right eye on 2010. Corneal graft was failed and then the IOP was high. The visual acuity of the right eye was light perception with good projection. But on the left eye, it is light perception also, but with wrong projection. Previously, the left eye had been treated due to the bacterial corneal ulcer. This is the eye of the patient. This is the right eye. As we could see, the failed corneal graft. And this is the one with the ulcer of the cornea. On January 2011, the patient had combined Boston Kipro with Orbis at that time with Dr. Antonio Aldafe, and I performed the Ahmed implant surgery on the right eye. I've done with limbal-based Ahmed implant in 2011. As you could see, the eye is very hyperemic, It was done under general anesthesia. I did the Ahmed implant first, and then Dr. Antonio Aldafe actually did the Boston Key Pro in this patient. As you could see that I did the Ahmed, and then also the difficulties is, I think, when we try to put the tube on the very hazy cornea, it is like, just guessing whether, I hope that it is in the right place. So I put that, I will show you. You see, I try to cut the tube, and then I make the paracentesis, and then I try to insert the tube blindly, actually, because we don't know whether the condition of the eye is good or not. At that time, we don't have UBM examination, so I can't show you the UBM examination in this patient eye. So after I put the tube, and then I close the incision, and then Dr. Anthony do the Boston Key Pro. On February 2011, we got a surprisingly visual acuity of the right eye was 4 meter finger counting. The patient was given prednisolone astatine 3 times and combined prostaglandin analog and beta blocker 1 time daily. This is the condition of the patient. But on July 2011, the IOP of the right eye increased despite maximal glaucoma medication. Thus, the patient was treated with transcyclophotocoagulation in 2 quadrants. And then on December 2011, the visual acuity of the right eye was 6.9 with contact lens, and the IOP was controlled with 1 glaucoma medication. This is we managed to perform the perimetric examination. As all you could see that it is very tunnel vision in this patient eye, and then also the condition of retinal fiber layer is very thin in this patient. The second case is Mrs. L, 35 years old, with secondary glaucoma due to uveitis, tuberculosis in both eyes, post-trabeculectomy. So this lady was actually referred to our hospital on September 23rd, 2013, with severe complaint of blurred vision both eyes since 13 months before admission to our hospital. And then she had trabeculectomy both eyes a month ago in other hospital. But as you could see that the visual acuity of both eyes were light perception with good projection on both eyes. The IOP on the right eye was actually 17 millimeter mercury after the trabeculectomy, and the left eye was 39 millimeter mercury with very shallow anterior chamber, both eyes, and mature cataracts. She was treated with oral acetazolamide 3 times daily, kalium tablet 2 times daily, beta blocker 2 times daily, brinzolamide 3 times daily, and betamethasone 6 times daily, and cyclosporin 2 times 100 milligram. Also, the internal medicine gave her Rimstar. It is the tuberculosis drugs with rifampicin, isoniazid, pyrazinamide, and ethambutol 1 time 4 tablets a day, and methylprednisolone 3 times 8 milligram a day with multivitamin. You could see the eye examination on the first day she came. The shallow anterior chamber on both eyes, and then also the peripheral anterior synechiae of the right eye, as we could see in here. And then also we could see total block of the pupil and the mature cataract in both eyes. And on USG examination, as we could see, there is no retinal detachment, but we could see that there is a choroidal thickening. I'm sorry. So I only told the patient that we try to help her eye. We do the Ahmed implant and phaco IOL on the left eye on September 26, 2013, and on the right eye on October 21, 2013. With this was done on 2013. As I sometimes I use the limbal-based, sometimes in the fornix-based implant surgery. At first, I tried to put the plate, and after I put the plate of the Ahmed, and then I will do the phacoemulsification first. As you could see, because it is totally blocked, I try to open up the pupil, and then after that I do the phacoemulsification in her eyes, and then put the IOL also. And then after we do the phacoemulsification, we insert the tube into the eye. At this, we know that the anterior chamber already deepened, so it is more easy. It is easier for me to put the tube and then close it with a scleral graft upper the tube, and then close the conjunctival peritomy like this. On the last condition, after 4 years, the visual acuity of the right eye was 612 with correction, and the left eye was 620 with correction. It is actually a miracle for me and also a miracle for the patient. The IOP of the right eye was 11 and the left eye was 13 without glaucoma medication. The patient then moved to another city, and the last time she came to our hospital was on 2021 with best corrected visual acuity 612 on the right eye, and then on the left eye 620 with the IOP of both eyes were 10 millimeter mercury without glaucoma medication. This is the peak on 2014 actually. She come to our hospital usually every year after that, after she moved to another city. Since 2017, we are able to use our own developed GDD that was made by polymetal acrylate with non-valve and then implanted between muscle. I share cases with you with Mrs. HDS actually came with a neovascular glaucoma on February 18, 2022 with the neovascular glaucoma of the right eye due to proliferative diabetic retinopathy. The visual acuity when she came was actually 1 meter finger counting with IOP 56 millimeter mercury. The patients had VGI implantation on March 9, 2022. I just did the using, I will move forward. It is also the limbal base. Actually, sometimes I use the fornix base, but in all of these cases, I did with the limbal base. Because this is non-valve, so I have to tighten the tube, and then I try to make it not fully closed, so there will still leakage in the tube, so I don't have to do the shunting in the tube for my patient. I try to make it like maybe about 90% close, so it is still leakage a bit in the tube, like that one. So I will tighten the tube 4 times, and then I put the implant, and then I suturing it in the sclera, and then I inserted the tube into the anterior chamber like that. And then I put the scleral graft over the tube to prevent the tube erosion. And then I close the peritomy tenon first and then the conjunctiva later on. The last condition on November 3, 2022, the best corrected visual acuity, it's very lucky for this patient. It's improved to 645 with the IOP 11.2. We could see the bleb and clear cornea, deep anterior chamber with tube. And then, but the lens is a bit hazy. We could see then there is a pale optic disc in the eye. So we actually plan to do the phaco IOL and anti-VEGF injection on the right eye, and also timolol 1 times daily for the right eye. We also have asked the patient to control to the cornea, to the retina division to have panretinal photocoagulation. The last cases is actually male, 37 years old with juvenile glaucoma. On October 14, 2020, patient referred by an ophthalmologist to uncontrolled glaucoma despite having filtering surgery on the right eye. The best corrected visual acuity of the right eye was 6.6 with cup-disc ratio 0.7, 0.8, and then on the left eye was 6.6 with cup-disc ratio 0.5, 0.6. Then on October 19, 2020, the patient had a VGI implantation on the right eye. The patient actually experienced hypertensive phase for 3 months, and the IOP then was well controlled afterward. This is the surgery in this patient. Actually, it is quite the same with the previous patient. I tried to make the closing of the tube not 100%, but around like a 90-95% of the leakage on the tube, so I don't have to do the shunting and on the tube with Vicryl 6.0, and then I put that as usual, and then put the tube using the 25 gauge needle to insert it to the anterior chamber. I think it's quite the same with the previous patient. The visual field on November 18, 2022, it is actually quite nice. This is the right eye, and this is the left eye. Actually, the left eye also has a trabeculectomy afterward. I will share you. So the last condition on December 13, 2022, the UCVA of the right eye 6.7.5 with IOP 10 millimeter mercury, but it's very lucky for this patient. The cup-disc ratio is 0.5, 0.6. As you could see that previously it is 0.7, 0.8 when he was first coming to us. He had post-trabeculectomy and then post-VGI in our surgery in our hospital on October 19, 2020. And then he also has a phaco IOL operation on January 3rd, 2022. But now he had no glaucoma medication in the right eye. In the left eye, actually the UCVA is 615 with IOP 11 millimeter mercury with cup-disc ratio 0.4, 0.5. He got the trabeculectomy and mitomycin C in our hospital on September 6, 2021. And then, I'm sorry, it is not 20, the phaco IOL is actually September 26, 2022. So it's about a year after the trabeculectomy. And now the left eye is controlled with PGA and beta blocker and brinzolamide 3 times daily. So take home message, GDD is one type of management in refractory glaucoma. We should try our best to help our patient even in a kind of impossible case. Hopefully, our efforts will help to preserve the visual function. Thank you so much from Indonesian Glaucoma Society.
Thank you very much, Dr. Aksayana.
I think now is the time to introduce our chairman, Joseph Anthony Tambakon. He is the past president of Philippine Glaucoma Society and now the board member of the Asia Pacific Glaucoma Society. And he is now working as head of the glaucoma section at St. Luke's Medical Center, Quezon City, consultant at the St. Luke's Medical Center, Global City, and as a professor of ophthalmology at St. Luke's College of Medicine in the Philippines. Over to Professor Joseph Anthony Tambakon. And
thank you very much.
On the what's next if the GDD fails is very important because we talked about GDD the last episode, but you will have to talk even the GDD fails, what we can do. Thank you very much. Please go ahead.
Yes. Thank you very much, Professor Nazarul Islam. Again, in any surgeries, a lot of times you are quite successful, but sometimes in our surgeries, it doesn't go well. And we need to know what's next, especially if the surgery of last resort that isn't functioning as you would expect. So that's the title of my talk. What do we do after a glaucoma drainage device fails? So these are my financial disclosures. None are relevant to this talk. As Dr. Vernam already mentioned, tubes are really quite a good procedure. This is usually indicated in eyes that have a higher risk for failure, with trabeculectomy with mitomycin C, or other glaucoma surgeries. As shown by Dr. Verna, it is a robust and versatile procedure. However, some eyes with tubes still need additional intervention even after the glaucoma drainage device surgery. This is usually due to thickening of the capsule that forms around the plate, making the aqueous not to percolate through that capsule, so the pressure sometimes goes up. We are quite fortunate that we have some intermediate term studies showing the outcomes of glaucoma drainage device, whether it's the AMED or the non-valve implants such as the Barvelt. We're talking about the ABC or the AMED Barvelt comparison study, the AVB study or the AMED versus Barvelt, and we could also get some insights in the TVT study. All of these publications shown here have 5-year follow-up, which is quite, we could get some idea on what we could do next if our glaucoma drainage device fails. Fortunately, we have a pooled analysis of the 5-year outcomes of the ABC and the AVB studies. Both of these studies have similar population, intervention, and comparators, even the outcome measures. The outcome measures of the AVB studies are a little bit more strict in terms of success criteria, failure criteria in terms of IOP. In a nutshell, both the AMED and the Barvelt implants were effective in lowering the intraocular pressure. From a baseline of around 30 millimeters mercury, the AMED was able to bring the IOP by 49%, while the Barvelt around 60%. There were less glaucoma medications needed with the Barvelt implant and lower IOPs with the Barvelt implant at 5 years. Both had similar visual outcomes. The probability for failure at 5 years was higher with the AMED implant. This group had needed more glaucoma, additional glaucoma surgeries as compared to the Barvelt, while the Barvelt had a slightly higher risk for hypotony, being a non-valve device. Now, if you look at the cumulative reoperation rate, that means an additional glaucoma procedures of the ABC-AVB studies, we could see that approximately 1 out of 10 post-Barvelt patients will need an additional glaucoma surgery, while 2 out of 10 post-AMED implant cases will need additional glaucoma surgeries. And the 2 most common surgeries is either another tube or a cyclodestructive procedure, such as translateral cyclophotocoagulation. For the ABC study, there were more patients who underwent an additional tube versus cyclodestructive procedure, while the AVB and the TVT study, it's almost 50-50 whether they had a second tube or translateral cyclophotocoagulation. So if a tube fails, what are the outcomes for the options? Do we do another tube? Do we do cyclophotocoagulation? Do we excise the capsule that's quite thick, leading to an elevation of the IOP? If you look at the studies on just exciting the fibrotic plate capsule, the success is not so great. It's maybe around 58% in 3 years. If you look at the second tube after a failed tube, the success rate is a little bit higher at around 88% at 1 year and around 83% at 3 years. But we have to remember these are retrospective case series with a lot of confounders and variables. Now, in a retrospective cohort, which is a slightly better study, the patients who had the second tube had a better survival. Additional treatment was needed at around 73 months. However, around 60% needed additional intervention, while those who underwent cyclophotocoagulation required further treatment earlier, but less number of patients needed further treatment. In another retrospective case series comparing a second tube versus cyclophotocoagulation, it basically says the same thing. The survival of a second tube is better as compared to the cyclophotocoagulation, but there's more post-operative complications with a second tube. So back to the question, what do we do if the tube fails? Well, which one is better? Well, the jury's still out. There's really lack of strong evidence. A lot of studies have heterogeneous populations with varying comorbidities and confounders and varying outcome measures. We need to individualize treatment based on the risk and benefits of the options for each of our particular patients. After a tube and the IOP becomes uncontrolled, this is my thought process when I see this type of patients. First, I have to check first if the device is still functional. So you want to check if the aqueous is still flowing to the plate. You could check this by checking the height of the capsule of the implant plate. If there's no fluid percolating through the tube, then you would note you could see the silhouette of the plate. Check for any tube obstruction. If there's any tube obstruction, then you could do laser of the tip of the tube or even the lumen of the tube. The obstruction could be fibrin, could be vitreous strands, especially in patients who have an posterior capsule that has been violated. If it's a pupillary block mechanism, then you would want to do a laser iridotomy to allow the aqueous access to the tip of the tube. If the tube is functional, then we could consider a second tube or cyclophotocoagulation. If the patient has good visual potential, I tend to go for a second tube. The question is, which one would you prefer, a valved or a non-valved device? My personal preference, if the first tube fails, then I go with the second tube is a non-valve with an inferonasal or inferotemporal placement. If immediate IOP reduction is required, then maybe I would use a valved implant or a non-valved implant with venting slits. If with previous AMED and you want to use a non-valved implant, you could excise the capsule of the original AMED implant, then insert the non-valved implant, fully occluding it. By the time that the capsule in the original AMED becomes again thick and the IOP rises, the second non-valved implant would be working at around 4 to 6 weeks. Here's a patient. This was a case of a patient who needed a second implant. The patient was referred to me way back in 2005, a 21-year-old pseudophakic female with medically uncontrolled uveitic glaucoma. I placed an AMED implant. The IOP initially was in the low teens. However, it went up to the mid-20s at 2 years. And there was moderately advanced damage, optic nerve head damage. So in this case, I placed a second barbell implant inferotemporally 2 years after the AMED. And after putting that, the pressure was controlled to around 18 to 14 millimeters mercury for the past 15 years, while maintaining the visual acuity at a decent level. The patient still requires one aqueous suppressant, but the patient and also some topical steroids once the uveitis acts up. But so far, the patient is doing quite well. Now, if I decide to do cyclophotocoagulation, we just have to be careful. We don't want to do over treatment. Options for cyclodestructive procedure, the most common is translateral cyclophotocoagulation. You may consider micropulse diode. However, the effect is not so great as compared to the traditional translateral CPC. If you have endoscopic CPC in your institution, and this is a very good option. The pearls here is to titrate the treatment. You don't do the usual 270 degrees. I usually do 90 degrees at a time, wait for around 4 to 6 weeks, see where the IOP levels off, then add if the IOP is still insufficient. If your tube is still functional, you don't want to push this eye into hypotony. I usually avoid this in patients who have chronic or recurrent uveitis, those who have active anterior chamber inflammation, those who have a leaky blood aqueous barrier, or for those who have a risk for cystoid macular edema. If, again, there are other options, as I mentioned, I think Professor Nazrul mentioned this. Some have advocated maybe trying out MIGS after a failed, but my success rate here isn't so great. You could also excise the capsule, but this is usually temporary. It lasts for just a few months, because if there's an aggressive healing response in the first surgery, even if you excise the capsule, it was more often than not recur. And usually my batting average here is only 30% success in around 3 years. So in summary, if a second tube fails, if your first tube fails, then a second tube or cyclophotocoagulation are the viable option. However, we have to remember that the next treatment step should be individualized based on the individual risk and benefits for this particular patient. We have to just be aware of the potential complication of each option and just try to decrease the risk. Again, thank you for inviting me to give a talk in this meeting, and I look forward to our discussion later on.
Thank you. Thank you very much, Professor Joseph Anthony Tambakon. It was really good to see you. We have option, even the tube fails, definitely. And you have already mentioned you can give the second tube. I think you can also do third tube, fourth tube also. We'll have a discussion on that. So I think next speaker, Professor Colin Clement. Will you introduce Professor Tambakon?
Yes.
Okay,
yes, it's a privilege to introduce our next speaker, Dr. Colin Clement. He is a clinical senior lecturer at the University of Sydney and honorary medical officer in the glaucoma unit, Sydney Eye Hospital. He's currently the treasurer of the Asia Pacific Glaucoma Society. His clinical and research interests are focused on minimally invasive glaucoma surgery and non-penetrating glaucoma surgery. The title of his talk is What to Do When Things Go Wrong, Dealing with Complications of Glaucoma Surgery. Colin?
Thank you, Professor Tambakon, for the introduction and the invitation to speak at this meeting. And thank you to the Bangladesh Glaucoma Society and APGS for the opportunity. I will just share my screen. Hang on. Bear with me a second.
You can see your screen.
Yeah, I've got.
There is a arrow in the left bottom. You can put the arrow. Press the arrow. Then it will.
Yeah, no, my problem is that the Zoom is showing over my display.
You can stop share and reshare if you would like.
Yeah, that's what I'm trying to do, but I can't see my arrow. Oh, my apologies. Oh. Oh, okay. Yeah. Okay, I think we're in business now.
Yeah. You can go to the slideshow, please.
Okay, I'm ready.
It's fine.
My apologies.
Okay,
Okay.
great.
Here we go. So I've been asked to talk about dealing with complications of glaucoma surgery. Now, if we're talking about all glaucoma surgery and all complications, that's a very extensive talk, and I've been allocated 15 minutes. So rather than skimming over everything very briefly, I've elected to focus specifically on trabeculectomy. The reason being that trabeculectomy remains the gold standard of glaucoma surgery, and it really sits at the core of any glaucoma service in terms of surgical management, and that's irrespective of whether you're in Bangladesh or the United States or Australia or any part of the world. Now, in terms of your approach to dealing with the complications of trabeculectomy, I've broken it down into these 4 broad areas as a way of conceptually thinking about how to approach it. So first of all, when we're undertaking trabeculectomy, we should be preempting complications. So looking out for patients that are at risk of developing particular complications, which then allows us to take the necessary precautions to minimize or prevent them from occurring. We should be able to identify complications when they occur, which then allows us to respond in a timely manner. I think having an understanding of the natural history of certain complications is helpful, because that will help avoid unnecessary intervention or interventions that will ultimately be fruitless. And of course, we need to have the necessary tools to be able to treat the complications as they arise. So that's my overall approach. Now, I'd like to break it down in terms of the presentation to you in terms of operative complications and post-operative complications. So the 3 main operative complications are really conjunctival buttonholes and tears, scleral flap perforation, and intraoperative bleeding. And then post-operative complications, the list is more extensive, but it can be divided into 3 subject areas: high intraocular pressure with deep anterior chamber, a high intraocular pressure with shallow anterior chamber, and a low intraocular pressure. All right, so conjunctival buttonhole. The types of eyes that are at high risk of this occurring are those that have a very thin conjunctiva, or even eyes that have had previous surgery. Okay, now the things that are critical to this developing relates to tissue handling and also what particular sutures are used during surgery, and I'll talk about that in a second. Now, you need to be able to identify when a conjunctival buttonhole or tear occurs. Now, usually this can be directly visualized under the microscope, but sometimes side L testing is required. So it's important for the surgeon to observe at the end of the case the integrity of the conjunctiva, and as a matter of routine, probably apply some fluorescein once the conjunctival closure has been performed, just to check for any sources of aqueous length. Now, one way of minimizing conjunctival buttonholes is your method for tissue handling, and this is where differentiating between tenons, capsule, and conjunctiva is helpful. So if you adopt a technique where you handle the tissue predominantly via the tenons, then you're going to minimize the risk of a conjunctival buttonhole. Your selection of instruments is critically important, and I would encourage you to use non-toothed forceps where possible, as this is going to minimize trauma to the conjunctiva. And when suturing the conjunctiva, you should opt for a non-cutting designed needle. So this is going to cause minimum trauma. If a conjunctival buttonhole or tear occurs, you can correct it by performing a primary closure. If the health of the tissue allows, or sometimes you need to excise the area and close it either directly or with a flapper or graft. Another intraoperative complication is the scleral flap or hole. Now, there are eyes that are predisposed to this, predominantly those that have a thin sclera, so this can occur in high myopia, scleromalacia, other connective tissue diseases. Again, this is a complication that's usually directly observed, And it usually occurs because of surgeon inattention or inability to judge tissue depth correctly. Now, prompt identification of the buttonhole, flap, hole or tear will then allow you to make adjustment to correct for it. And actually, it is possible to just create another flap underneath and sandwich the two together, which would then give a watertight closure. And this can either be done by starting shortly behind the flap the same width, or creating a flap just outside the margins of the original flap. But this is contingent on there being a reasonable amount of scleral tissue available. If it occurs in one of these eyes with very thin tissue, such as myopia or scleromalacia, then this is may not be possible. In which case, another method of correction is required. Now, you could opt for an autologous conjunctival graft taken from another part of the same eye, which is already anesthetized. Now, this can either be a flap, which is positioned over, or it could be a free graft from another site entirely. Another option is to use some sort of donor sclera. And this is when I make the point at the beginning that preempting complications is important. So if you feel that an eye is at risk of a conjunctival tear or buttonhole and you have donor sclera on site, then it's very easy to do this. But if you haven't ordered the sclera and you don't have ready access to it, then it becomes a problem. An alternative to donor sclera is pseudoplast, so that's lyophilized pericardium, and that has a shelf life of 5 years and can be reconstituted and ready to go within 30 minutes. So that's a very handy product to have available. And when you do any of these scleral flap closures, pseudoplast closures, it's important to have a very tight, watertight, if possible, closure initially, and then this can be adjusted in the postoperative period. The third major intraoperative complication to deal with is bleeding. Now, the reason this can be a problem is that one, a lot of subconjunctival bleeding affects your visualization, which is going to have a flow-on effect to other stages of the surgery. Two, a lot of subconjunctival bleeding attracts fibroblasts and fibrosis, which could lead to blood failure. Three, you could end up with a blood clot that sits under your scleral flap, and this will act like glue, preventing aqueous from flowing into the bleb. And four, you could get blood tracking into the anterior chamber, causing hyphema, which is going to affect the patient's vision in the postoperative period. And this is particularly important in monocular patients. So the steps for trying to address bleeding is to stop anticoagulants prior to surgery, and this has been discussed by other presenters. You've also got to be aware that some vitamins will have anticoagulant effect. This includes coenzyme Q10 and ginkgo biloba, which some of our glaucoma patients are taking. And there are also things in the diet that patients are on, and the classic here would be turmeric or garlic. So any patients that have a lot of curry in their diet are at higher risk of intraoperative bleeding. Other steps that can be taken during surgery to minimize bleeding includes lowering the blood pressure if the blood pressure is high, using diathermy. Now, this should be targeted rather than diffuse, because diffuse diathermy can lead to tissue contraction, which will ultimately result in a leaky over-filtering bleb and may affect wound healing in the postoperative period. Another trick is to use vasoconstriction. So you can apply straight adrenaline or adrenaline in local anesthetic to pledgets, and they can be tucked under the conjunctiva to cause vasoconstriction. And that's particularly helpful for sources of bleeding that are deep under the conjunctiva. Okay, post-operative complications. So the first category is high intraocular pressure with a deep anterior chamber. And this occurs because aqueous is not adequately able to flow underneath the scleral flap and disperse in the subconjunctival space. Now, early on, this is typically because the scleral flap is tight, and this can be addressed by performing massage. That's already been beautifully demonstrated in one of the earlier videos. Other options are to release your releasable sutures or to laser the interrupted flap sutures. But I would say here that you should avoid as much as possible doing either the release or the laser within the first week of surgery, because ultimately those eyes will tend to end up hypotenuse. So you should look at other ways of controlling pressure. And then only from about a week onwards should you consider loosening or releasing sutures. It's important to have a look gonioscopically because there may be iris plugging the ostium, and this can be addressed by performing an iridoplasty, and if that doesn't work, sometimes a surgical revision is required. And another reason for looking with a gonioscope is you can have a blood clot which is sitting under the flap, preventing blood from flowing. Now, often you can just wait and this blood will break down and the flow will establish with the assistance of massage. Sometimes that doesn't occur. There is the option just to treat the pressure medically in the intervening period until the blood starts to disperse. But if you're really having trouble controlling the pressure and you need to break down the blood quickly, there is the option of giving an intracameral tissue plasminogen activator or TPA injection, and that is quite successful. Of course, the risk of that is that it can induce more bleeding. If you've got high IP and deep anterior chamber in the later postoperative period, this is often because of subconjunctival or subscleral fibrosis, and this can be managed by using subconjunctival antimetabolites injected in the clinic, performing needlings. In the case of encapsulation, using an aqueous suppressant can be useful, and if none of these things work, then ultimately a surgical revision in theatre is required. This may also occur because of a steroid response. Now, even though there appears to be a functioning trabeculectomy, it is still possible in patients who are steroid responders to develop a steroid response. And if you suspect this is the case, then withdrawing the steroid or switching to a steroid less likely to affect the pressure will help control the pressure in the longer term. Now, post-operative complication, we have high IOP and shallow anterior chamber can be broken down into pupil block aqueous misdirection or suprachoroidal hemorrhage. Okay, so we'll look at pupil block first because this is the one that really needs to be ruled out in the first instance. So in these eyes, it's important to carefully inspect the site of the iridectomy to ensure that it's patent, and it may not be patent either because it wasn't done properly, so it wasn't done properly during surgery, or because there's something sitting there blocking it, such as blood or fibrin. If that is the case, then the iridectomy should be opened further, and this can be done with a YAG laser in the clinic. This clinical picture may also occur because of aqueous misdirection, and the eyes that are predisposition to this complication are ones with a short axial length. So if you have an eye like this in whom you're performing trabeculectomy, it's worthwhile applying atropine at the end of the case and potentially in the first few weeks after surgery, because this will help protect the eye against this complication. Again, you need to confirm that the iridectomy is patent, and then you need to perform some sort of imaging, either UVM or B-scan ultrasound, to visualize the ciliary body to look for anterior rotation, which is one of the clinical signs. If aqueous misdirection is suspected, then initially it should be treated with atropine, and I would start with TDS to QID and then tapering down. Now, some patients can get very good long-term control with atropine alone, and you can get them down to as little as 1 drop per week. A good way of monitoring the effectiveness of your treatment is with repeat refraction. It's very sensitive to changes from aqueous misdirection. They develop a myopic shift. So If you are noticing a slight myopic change in the refraction, that's usually an indicator that the misdirection is recurring and you need to increase your frequency of atropine treatment. Another treatment to be considered when atropine is not helping is an anterior vitrectomy. Now, the idea with the vitrectomy is to create a unicameral eye. So this is where you have a direct communication between the posterior and the anterior segments. It's no good having a core vitrectomy, for example, where you still have the anterior hyaloid face intact, because this will not break the misdirection cycle. And then thirdly, high IOP with shallow anterior chamber can be due to a suprachoroidal hemorrhage. Now, the types of eyes that are predisposed to this are eyes in the elderly patients that have an extensive cardiovascular history and who are taking anticoagulants. Now, the suprachoroidal hemorrhage can be seen with direct examination by the slit lamp and can also be confirmed with B-scan ultrasound. Initially, the high pressure due to this should be managed medically if possible, and consideration given to reducing or stopping anticoagulation. And ultimately, the treatment will require a drainage of the suprachoroidal hemorrhage, but often this takes up to this should be delayed a few weeks until the blood clot has started to liquefy. If you try and do it within the first few days, it's often unsuccessful because the blood is a congealed mass. Indications for intervening early would be kissing choroidals or intractable pain. Okay, the other class of category of postoperative inflammation are those with low IOP. Now, this can occur with a shallow anterior chamber or a formed anterior chamber. And I've broken this into 5 categories. There's overfiltration, ciliary body detachment, conjunctival leak, aqueous misdirection, and ciliary body cleft. Now, we often talk about hypotony as a complication of trabeculectomy. So this is where the intraocular pressure is too low, and it's defined as a pressure less than 6 millimeters of mercury. Now, this is numerical hypotony, and this in itself is not necessarily a bad thing, because there are some eyes that can tolerate an intraocular pressure of less than 6 millimeters of mercury and have very stable glaucoma and normal vision. And in that case, the treatment is actually a successful outcome. And we've done a study in our centre and found that of all patients that develop numerical hypotony following glaucoma filtration surgery, 1/3 of them have structurally normal eyes. There's also structural hypotony, and this is when the pressure is low, but they develop structural changes related to that low pressure. And that can be choroidal effusion, macular folds, disc swelling, cataract, and corneal edema. Most commonly occurs when the pressure is less than 6 millimeters of mercury, and very rarely you can have it occur in eyes where the pressure is higher than 6 millimeters of mercury. So it's really the structural hypotony that we're concerned about. Now, when it comes to overfiltration, particularly in the early period, you can just observe, because often this will improve over time as a bit of fibrosis develops. You can encourage this process by reducing the amount of steroid the patient is on. Taking atropine can also help bring the pressure up slightly, but ultimately, if none of these conservative measures work, then the patient will require a revision. Now, this can either be a full revision where the conjunctiva is opened and the flap inspected and resutured and the conjunctiva closed again, or you can do a modified revision where you do something like a transconjunctival flap suturing. Now, the advantage of that is that it's a much quicker procedure and you can get very good results from it. Ciliary body detachment usually occurs in the context of a hypotony, which in itself causes hypotony. So it's actually a vicious cycle. So it's characterized by the presence of subchoroidal fluid. You can try treating these conservatively with atropine initially. Topical and systemic steroids can be helpful, but ultimately they often benefit from a drainage by performing inferior sclerotomies and draining the straw-coloured fluid. You also have to be mindful that if you don't address the initial cause of hypotony, then the ciliary body detachment may reoccur in the postoperative period. And then conjunctival leak can occur either early or late after trabeculectomy. You can initially try to deal with it with aqueous suppressants, reducing steroids and applying a bandage contact lens. And in many cases, this is successful. And you certainly should give a decent trial of this type of conservative measurement prior to considering more aggressive treatments, unless they have developed, significant hypotony-related changes, such as massive choroidals. Injection of autologous blood has been tried. My personal experience with that has not been very favorable, but some people do that. And the idea is that it causes a fibrin-type plug and leads to some fibrosis closing the hole. There have been reports of the use of riboflavin cross-linking to stop the leak, with some success reported, but it's really in eyes with a pinpoint conjunctival leak where success has been demonstrated. If the leak is more broad-based, there is no evidence for that at this stage. And then lastly, if none of those measures are successful, then you should consider a direct repair. Now, we've already mentioned aqueous misdirection as a cause of high pressure with a shallow anterior chamber following surgery. It can also be a cause of low pressure with shallow anterior chamber following surgery. And this is because sometimes the pressure is controlled by the functioning trabeculectomy, but you still get the anterior chamber collapse. The principles of assessment and treatment are exactly the same. And finally, a ciliary body cleft. Now, usually we see this after trauma, but it can rarely be induced at the time of surgery. Now, to identify this, you can, one, examine the eye with gonioscopy, but often you need to confirm it with UVM. And the other benefit of UVM is that you can localize the exact position on clock hours and the extent of the ciliary body cleft, which is useful when you need to repair. Again, you can try and control it with atropine, but often direct repair is required, and this is done via an external approach with a scleral cut down, exposing the underlying ciliary body and suturing the cleft shut. Okay, so in summary, complications can be avoided if anticipated and actions taken to avoid them. Identifying the cause of complications is a key to successful treatment, and appropriate interventions usually result in good outcomes. Thank you very much.
Thank you very much, Dr. Clement, for that very comprehensive talk. Maybe if Professor Shahid has any comments or questions regarding the presentations.
Unmute, please, unmute.
Thank you. All the presenters very nicely described regarding their own topics. Actually, in any surgery, there are lots of complications. So before doing the surgery, we must sort it out that about the pros and cons of the surgery, and we have to take the effective measures. And with all logistic supports, we need to proceed on for our surgery. And during surgery, we must be careful in each and every steps to avoid the complications. And there are lots of things, there are lots of ways to overcome the complication in post-op period, to have a clear vision of a person. And I may open the floor for discussion.
Yeah. Maybe I'll start off. Maybe just a question to Dr. Munir, or the rest of the panel as well. In their preference in applying mitomycin C during trabeculectomy, whether it's injection or via sponge, single application. What's your preference? Maybe we'll start off with Dr. Munir.
Actually, I prefer subconjunctival injection nowadays. Before subconjunctival injection, I use sponge application, but I think subconjunctival subtenon injection per tip. It is low concentration, so there is less chance of a postoperative vascular bleb, and due to subconjunctival injection, this dissection of the conjunctiva, I think it is more easy for me, particularly in the posterior direction. And I found that in the postoperative period, yeah, it is less a vascular bleb. At present time, I try to follow this technique.
Okay. How about Dr. Virna? What's your preference?
I'm still using the usually the compression, but if there is failed, so like maybe a week after or after the surgery, I could do the injection. So in the surgery, I use the compression usually.
So you use sponge application
Yeah,
with the
sponge
mitomycin
application.
C.
Yes.
Dr. Clement?
I use injection, and I prefer this because it minimizes anti-metabolite handling in the theatre and exposure to my staff. It is quicker, and I feel like I have better control in terms of the dispersion of the anti-metabolite into the areas I want it to go.
Okay, that's a good point. Again, safety for the staff. That's a very good point. And what concentration do you use?
I use 0.02%.
0.02.
Yeah, 0.1 mil.
Yeah.
So it's
And
equivalent to 20 micrograms.
Okay, great. How about Professor Nazrul?
Yeah, thank you very much. Actually, I had in mind to ask this question to all, but you asked it. Very nice. Actually, I am using in Bangladesh for more than 2 years now. I'm 2 years. I'm using the subtenon injection. Previously, I used to give 10 minutes before the surgery, but there is some study now. It shows that within 3 minutes, actually, it becomes absorbed. So from that time, I'm using only 3-4 minutes before I give this injection, and I mixed with the lidocaine. What I do, I either dilute 2 milligram with 7 cc BSS, then it becomes 0.3 milligram per cc like that. And from there, I take only 0.1 ml. So 0.1 ml of the MMC solution, I mixed with the 0.1 ml lidocaine. So it becomes again 10 times dilution. So it becomes very low concentration per cc. And I gave it subtenon at least 3-4 minutes before. I massage it, and Professor Munir already showed it. Just massage it, and it helps. He rightly pointed out, it helps for dissection also in future. Actually, I had a complication with a sponge with one of a very VIP patient. A very small fiber remains, and that caused a lot of reaction 3 years before. And after that, I thought what to do next. Then I found many people are using the injection subtenon. Then I tried to do that. And after that, I'm using the injection, getting good result. So that is my practice also, the subtenon, low concentration MMC I use mostly.
Yeah, that's just very good pearls in terms of the concentration, how to use it, and of course, making sure it doesn't go all the way to the limbus. You don't want to affect the stem cells when, so you just pushing at the back.
I use the lidocaine also is because the patient has more comfort, and most of the time for the advanced glaucoma, I don't give any perivalvular block. I just use this injection for the primary surgery. For the dissection is fine. And after that, I go subtenon injection. So the patient does very good with the subtenon. Only 2 cc is fine, the subtenon. So this way I find for the advanced glaucoma, where actually you cannot give the perivalvular anesthesia, very 9 cupping cases. So in that cases, it is my practice.
Okay, that's a very good point. I still sometimes I use sponge, sometimes I use injection. For those who have a little bit higher risk factors, I use the injection. But as a routine, I also use sponge. I'm not getting any different results, but again, for safety and for efficiency, the injection quite makes sense. There's really no randomized controlled trial which one's better, but again, what works in your hands, and you just evaluate the outcomes after. Maybe a question for Professor Nazrul. you eloquently mentioned about needling, how to revive a bleb. When do you decide to do needling versus bleb revision versus going to a glaucoma drainage device if you have a
Thank you
failing
very much. Thank you.
trabeculectomy?
It's really very important and practical question. First of all, you know that every patient we take, 50% of our patient may need ocular massage. Many patients post-operatively, we find the pressure is a little bit up and the bleb is not well formed. So under the slit lamp, direct viewing slit lamp, I massage the patient, and most of the patient do well. Few percent of the patient, they don't do even with massaging, maybe good after 2-3 months, they do not well. Then there is no way of massaging. There is no result of massaging. Then in that cases, we think even the cutting of suture is also no help. In that case, we think of bleb needling after 6 weeks to later. I try one bleb needling and many of the patients do better. But some patient, maybe after 3-4 months, they come again with higher pressure. I do the second bleb needling. So usually 2-3 is maximum I do. After 6 months or 6-7 months, if I find the patient is not doing well, that I think of doing the revision of the bleb, just opening and just dissection of the scar and making this a little bit less tight suture so the patient do well. This is my practice. And if it fails, then I think of doing the retrabeculectomy or the glaucoma drainage implant. If the patient is having kind of refractory glaucoma cases, say for example, neovascular glaucoma, inflammatory glaucoma, or the pseudophakic glaucoma, these are the cases straight away. Nowadays I straight away go to the glaucoma drainage devices, not the second trabeculectomy. This is my preference. But of course, if the patient cannot afford it and the patient having some problem or valve in our country sometimes not available, then we can go the second trabeculectomy. Definitely we can do. So this is usually I manage my patient.
Yeah, that's very individualized. Again, cost is
I forgot to tell that recently I have done some cases with needle goniectomy. It is the bang procedure.
yes.
This 10% I did the bang procedure, or some patient in the KDB also. And in 2 patients, I did the 360-degree trabeculotomy. So these are some options I tried, and I think it works before you take a decision for the second trabeculectomy or for the glaucoma drainage implant or the other procedure. So these are some kind of mix that you can help.
Okay.
And I have done 3 cases now. And Dr. Birna yesterday has seen this. The very small incision with I can do the Ahmed clear path. So after trabeculectomy, there is some fibrosis there. So if you use a small incision for this kind of glaucoma drainage device, it can be helpful, I think.
Okay. Yeah, very good tips there. Dr.
One
Clement,
thing-
yes,
thing I
Dr.
have
Munir?
to- yeah.
Yes.
One thing Dr. Professor Nadur nicely mentioned that how blood revision or needling what are doing here in our country, Bangladesh. So one thing, a clinical thing that before blood needling or revision surgery, we have to see gonioscopically the deep ostium is open or not. If the deep ostium is blocked by peripheral iridotomy or other thing, in that situation, blood needling or other thing would not be happen. So first thing we have, before doing this, we have to do the gonioscopy and see the deep ostium is okay. It is my practice routine thing.
Yeah, that's a very good pearl. You have to look at the level of blockage. It might be you might be needling, you might be beating the wrong horse there.
Already I
Dr.
mentioned in the presentation
Yeah.
that you must do the gonioscopy to see is any iris, any vitreous, or any blood clot. Already I mentioned it. But one thing is that if there is something like that, you can also, Dr. Devendra Grover has shown very nicely that you can go internally also you can clean the ostium also from the inside. This is a good point.
Yes. Yes. Even you could do even a laser procedure. Using a
course.
gonio lens if you have something there. It's something simple.
It, yes.
Yes. Very
Thank you.
nice. Dr. Clement, do you have any experience of doing a mixed procedure post after a failed trabeculectomy or a GDD?
Not GDD, but I have had some experience in failed trabeculectomy. The mixed procedure I use is iStent inject. and the success has been variable. I think one thing we don't really know about after trabeculectomy is the integrity of the Schlemm's canal and outflow channels.
Correct.
There's a possibility that when you divert aqueous via trabeculectomy, that the traditional outflow channels shut down. Now, whilst in theory, a MIGS like an iStent, which is transtrabecular, can resuscitate those outflow channels, if there's a degree of fibrosis, then it's just never going to open up. So the numbers I've done are small. I've had some wins and I've had some failures.
Yeah, same here. Sometimes it works after I try to do iStent. With a Zen, it works. It's just like a second trabeculectomy, but with a trabecular bypass procedures, sometimes it works, sometimes it doesn't. Maybe a question for Dr. Verna. It's quite interesting that you have your own device. What's the surface area of the play?
Well, 200.
200.
Yeah,
Okay,
200.
so something like a Barbell 250. It looks actually like the Multino 3.
Yeah, it is. Because actually
Yeah.
it was developed with Professor William Morgan from Perth. And
Okay.
yeah, so we developed it together actually for the design, but most of the research done by me.
Okay, so what's the cost, if you don't mind me asking? Because like we have the low cost alternatives, the AADI, which works
Yeah, I
quite
know.
well.
Yeah.
What's the cost of the Verna implant, and where is it available?
It is about what I think in our country it is about 2 million. So it is around 100 or 150, around 100 or 150, because now US dollar is around 16 to 17,000. So it's around between 100 and 150 dollars.
Yeah,
Between that,
that's
US dollar.
that's quite reasonable. Quite reasonable. Go ahead, Professor Nazrul. Yes.
Can I have the same kind of question to Dr. Vinna also? You have shown very nicely the very challenging cases you have shown, and your implant did very well to that result we have found, especially the grapes ophthalmopathy and uveitis post-trap, this cancer. You have mentioned that you do not do any fenestration because it is a non-bulb device.
Yeah.
So in our practice, in my practice, what I do, I ligate it. I do 3-4 fenestration so that first day, second day, I have a little bit less pressure. You know, these people having 40, 50 IOP, after the device, if the patient again and 40, 50, the vision will decrease. So what I do, some fenestration, and I check it with a sponge, the aqueous comes or not. When the aqueous comes, usually I get 25 to 35 IOP in the second day in my non-bulb devices. So as you've shown that you do not ligate completely. 90% you ligate it, and so that there is some leaking, so the pressure in the first, second day is less, right?
Yes.
Right.
Yes.
So how do you measure that is 90% tight? Because it is very difficult that even if it is very much say 80%, lot of leakage, hypotony second day.
Yeah, you know.
Really a challenge for that. How do you measure that?
So usually nowadays I could measure it by if you like pushing a bit hard. So if you push a bit hard and then there is still leakage, then it is okay. So it is almost close, but you have to be a bit using a bit power to make it there is a leakage in the tightened tube. So I measure it like that. If it is too easy, when I push the flow and it is too easy, then it is not enough. So I will tighten it a bit. So I will get a bit like hard pressure in the tube, so then I will be sure that it is enough.
So
Professor,
drop by drop will come. Only a drop
will, only a drop will come.
That way you can understand a little leakage is there.
Yeah.
So I will try this thing.
Thank you.
Yeah. Professor Shahid, would you like to comment?
From core of my heart, I must congratulate Virna as a woman for his invention of shunt. Now I have a question to you that totally is that the device is designed by you, or how you managed, or how long it has been taken to manage it?
So actually it is quite long research. I started from 2011. So and I got my implant marketing in Indonesia on 2019. The research actually take place from 2015 until 2017. So the 2011 to 2015, I tried to make a prototype. So like measuring the rectus muscle, and also at first it is really exactly like Molteno. It is like it is round. But then I think that it is a bit difficult. So I cut the side, so you could see that it is a bit round in the other side, but it is just straight in the other side. So it is actually the modification when I make the prototype. And also we try to have like the tube, the silicone tube, and also we try to have the glue to link between the plate and then the tube, like that. So it takes about 4 years for me to have the prototype. And then we do with the rabbit eye, and luckily I've got one rabbit with glaucoma actually. So it is in my report. And then this rabbit is actually got help with the implant. After 2 months, with the hazy cornea and then the ophthalmic eye, the 2 months rabbit has a clear cornea, and I could see there is a coloboma of the iris in the rabbit. So I'm sure that it's quite helpful even for the rabbit. Then I move forward with the subject with patient with advanced, not advanced, but maybe almost not see. So like a patient with no light perception or with light perception eye in our institution. Only 2 patients first for about a month, then 15 patients for about 3 months. And then we follow up this 15 patients for about a year. After a year, then we have to move through until 2017, about 100 patients. Then we got the permission from our Ministry of Health to market this implant. Yes.
Yeah, congratulations, Dr. Verna. Yeah, I
I
think
have a
we're running.
question.
Oh,
I
go
have a
ahead.
question,
Yes, of course.
Dr. Verna.
May I ask a question to you, Dr. Tambakun? Because
Yes, sir.
your presentation was very nice. We got some hope that even the tube fails, we have something in our hand. So you have asked that how many tubes actually we can implant in a patient? Say 1 tube fails, you said another tube, of course you can implant. How many tubes you can implant in the eye?
I have a few patients with 3 tubes.
3 tubes. Yeah.
3 tubes.
tubes.
Again, you just again, it depends on what tube do you put placed in, because there's just a very limited real estate around, between the recti muscles, and you don't want to have any motility problems or strabismus. So with 3 tubes, I have a few patients walking around.
Thank you. I have another question, that if a patient having with the cystic bleb, after one of my patients came like this, was syndrome children. At 5 years, I operated her. And after 10 years, that is 10 years age, after 5 years, she came with higher pressure, about 45, 50 like that. Then has a very big cyst. So I tried to needling first. It didn't work any well. So after 1 month, I opened it, and a big scar, fibrous tissue was there. Totally, I removed it. And the same Ahmed valve, the AP8, the children variety, I put it with Ologen. Over that, I put Ologen, and I re-implant the same valve, same thing. And after a few weeks, I find she's doing very well now. I've seen her after that. So how do you think that this way the same valve can be implanted, or you need
you mean taking out the capsule, excising the capsule of the plate?
Yes, totally.
Yep. Sometimes it works, sometimes it doesn't. My batting average is around 30%. 1 of the 3 will work.
Okay.
But sometimes, again, it depends on the risk factors, because again, if you have a exaggerated healing response, especially in children, even if you take off that capsule, sometimes it just comes back. I'm not sure what the experience of the others with regards to excision of the capsule. Yes, Colin.
I just wanted to ask whether you use anti-metabolites when you're doing the revision of the capsule.
I use mitomycin C when I revise. How's your
for
batting
your
average,
tube,
Colin?
for your
Oh,
tubes?
for routine? No. Routine,
No,
no.
no, but if you're doing a revision, you do.
If I'm going to take out, excise the capsule, I do. I'm not sure if it works. There's really no clear evidence with regards to antifibrotics in glaucoma drainage device. The healing process at the posterior to the equator is different from anterior to the equator. So I'm still not convinced that there's strong evidence. Some do it. That's okay. But again, it depends on your outcomes. How about you, Colin?
Yes.
Do you use antifibrotic for primary implants?
No, generally no. I think it increases your risk of complications like scleral melt.
Mm-hmm.
So
Agree.
I try to avoid. Yeah.
Yeah. If you dissect posterior to the equator, there's not much episcleral tissue there. Dr. Munir, you raise your hand.
Yeah, I have a question that in the vitreoretinal surgeon usually use the silicone well, and then the retinal detachment surgery.
Yes.
And silicone-induced glaucoma, refractory glaucoma, trabeculectomy cannot do as 360-degree band buckle there, given conjunctiva is fibrosed, and there is band. So placement of GDD is difficult in this situation. What is
Yes.
your comment on your how we can manage in this situation?
I usually, yeah.
Or
So an
how-
oil with a silicone band, usually I put it inferiorly, inferior-temporally, or inferior-nasally. Me just make sure you could excise the capsule of the band and then suture it directly in the band. Usually the band's around 8 to 10 millimeters right at the anterior edge. So I bite sclera, band, then through the fixation holes of the device. It works quite well. Another option is doing a socket type of implant. If you have a tube available, you could just use the capsule of the
Band buckle.
episcleral band. Yeah. So I just do it inferiorly. Yes, Professor Nazrul.
Actually, I wanted to comment on Professor Colin Clement. He has done so beautifully the complications management. It's so practical situation we face, all of us. And he have tell very nicely every step of the complications that can happen, how we can manage. And I'd like to thank you very much for that. I have one
Yes.
very small question
My
to you,
pleasure.
Dr. Clement, and that you are
Yeah.
using steroid. In some cases, we find about 20% we find that there is higher pressure steroid responder, and you told obviously that you can stop the steroid and give something other than that. The problem is if we stop the steroid, in these cases, there is a chance of inflammation more. It is the patient already trabeculectomy done, so we cannot stop steroid most of the time. So what we do, we give a steroid, at the same time we give some anti-glaucoma medication adding with this. And we give the less potent steroid like loteprednol or fluorometholone like that. So what do you suggest in these cases? That stop?
Yeah, I agree with you. And I did mention briefly that you could switch to a type of steroids such as loteprednol, which is less likely to have an effect on the pressure.
Yes.
So it's, I mean, the key principle is that you have to look after the bleb health and integrity. And if you allow inflammation to progress unchecked, then ultimately the bleb will fail. So that has to be the primary concern, and then manage the pressure accordingly, using a preservative-free topical IOP lowering medication in the short term can be helpful. I agree.
Thank you. Thank you very much.
I think, Prof, we're running out of time. It was a very healthy discussion. Yes. Again,
Please.
I would like to thank all the speakers, Dr. Virna Triana, Dr. Munir, of course, my co-chair, Professor Nazrul Islam, Dr. Colin Clement. It must be 11 p.m. already in Australia. Thank you. Professor Shahid, again, thank you for having us. Professor Nazrul, any last words?
Yeah, I also like to thank everyone, especially to you, Professor Joseph Anthony Tambakon. You have taken a lot of trouble to organize this symposium. And I'm grateful on behalf of Bangladesh Glaucoma Society to the Asia Pacific Glaucoma Society for exchange program and this kind of symposium. And we have learned a lot. And this program is in the YouTube and also in the Facebook. Many hundreds of people are watching us. So I think we have learned many practical tips from this symposium. And I also like to thank all the speakers, Professor Colin Clement, to you, Professor Joseph Anthony Tambakon, Professor Birna Asrori, and my colleagues, Professor Iftikhar Munir, Professor Zakir Shahid, for being here. And lastly, not least, is my attendants who are watching this symposium. To all of you, thank you very much. Thank you.
Thank you, everyone.
Thank
Thank
you,
you.
and
Thank
stay
you.
safe.
Thank
Stay
you.
safe.
Thank you.
Thank you very
Good
much.
night.
Thank you. Good night.
Thank you. Good
Good
night.
night. We're leaving. Thank you very much.
Thank you. Assalamualaikum.